The statement is patently false that sugar can't cause diabetes or obesity.
That is not science, that's a lie, Travis.
They don't study the science. We really have a messed up system.
40% of adults are considered obese.
In the UK, obesity rates have doubled.
The numbers are not looking good, unfortunately. Experts say this is an alarming trend.
Do we have control? Hyperpalatable, high-fat, high-calorie foods that we are naturally attracted to.
Is bariatric surgery sort of like forced evolution?
This is the most unscientific discussion I've ever had in my life.
You wouldn't recommend a keto diet?
It's not the carbs. We'll get to that.
Today, we're here with the extraordinary
Dr. Garth Davis, the author of Proteinaholic.
We're not born to get operated on. Think before you eat. I read everything on it, and then I read your quotes, and I disagree with you.
Oh my God, you are a moron.
Open your mind to listen and to think about that a plant-based diet could just change your life and every disease that I treat.
But obesity is clearly a disease.
Diet is everything. How did I not know this?
With that said, welcome Dr. Garth Davis to the show. How you doing?
Thanks so much. Very good. Good.
Yeah, it's really great to meet you. I'm very excited about this. So just to start it off with a really simple question. As bariatric surgery, is that been your main and only focus from the start? What drew you to that?
No, so I'm a general surgeon, and I started off in general surgery. I joined my father in practice, actually. Mm-hmm. And so general surgery is any kind of GI surgery, gallbladder hernias, small bowel surgery. At the time, bariatric surgery was really starting to take off. So obesity was going like this, and all of a sudden, people started figuring out how to do the bariatric surgery, which is a fairly complex surgery, but doing it through small incisions laparoscopically, making it a much less morbid procedure. But it took a lot of skill to do the surgery. And the chairman at my of my department asked me if I wanted to, start looking into doing this. And I was like, I'll try it. I'll give it a try. And the surgery was very challenging, but the results were so dramatic. Like, you just don't get those results. I would do big cancer surgeries, and when you get rid of cancer, but cancer would come back, things like that. I would do a gallbladder surgery, never see the person again. But with this surgery, I was seeing very dramatic results, and it was really helping people. And it was like, oh my gosh, this is just a great surgery. And then they just grew and grew and grew. And I've always kept my general surgery and my other, type of medical specialty, but I became increasingly interested in weight loss and obesity.
One of the things that I've picked up from learning about you is that there was a realization at some point that like 85% of the reason people are in hospital is because of diet. Was that just something you just noticed during your general practice as a doctor? Like, how did that realization come about?
It's funny how it really is an evolution. In the beginning, I just thought, I don't know what I thought. I kind of thought there probably was a little bit of that blame game against the patient. They should have just, done differently, but I wasn't healthy at the time at all either. I mean, I was overweight and sick, but I didn't. The other part of me, I guess, was thinking, well, I don't really care. There's a problem. I'm going to fix it. That's a pretty surgical mentality, right? There's a problem. I'm going to cut it and fix it. That's how surgeons are. We're pretty results-oriented and task-oriented. But I became increasingly closer to the patients, and as I did, I became increasingly interested in what is it, I wasn't that healthy, but what made them even more unhealthy than me? What was driving this? Why are they more unhealthy than their colleagues? What is their general lifestyle? How are they eating? What are they doing? And the more I started learning about this, the more I started thinking, wow, we really have a messed up system, because there's parts of the world that don't have these diseases. In the meantime, my wife got pregnant and I needed to get a life insurance policy. And I go to get my life insurance policy, completely failed the test. So I had elevated liver function tests, meaning I had fatty liver. I had very high cholesterol. I had hypertension. And I was like, oh my God, I am on the same path, right? I'm on the same path I've seen many others take. Maybe I won't get to the morbid obese level, but I will get to a level that is going to affect my lifespan and health span. And so then I really started saying, okay, medicines fix a problem, but what created that problem? And that's when I really started this kind of journey into looking at what creates disease.
And when did you make the connection to the plant-based diet?
It was right around that time, because I started, we didn't learn anything about about this in medical school. Not in my day. I think it's a little bit better now. But back in my day, you were sick, you took a pill or a surgery, and that was it. And so the thing is, I knew, I go and see a buddy of mine. Oh, no problem. We'll put you on a statin. We'll put you on some blood pressure medications. No one said, eat differently. That just wasn't, considered. But I started looking at the literature, and I start, coming into paper. Like, it was interesting to me to find out that there were parts of the world that didn't have heart disease, whereas we're all dying of heart disease. In this country, it doesn't matter what race or creed you are, you're still dying of heart disease. And so, these other parts of the world weren't having it. And so I started looking at, some of the work that had been done by Ansel Keys and some of the work that had been done by Dennis Burkett, and started realizing, like, wow, it really is the environment, it really is the diet. And the more I studied the diet, the more shocked I was at, wow, diet is everything. How did I not know this? I mean, it seems obvious now, so it's weird talking about it. But back then, it was like, hey, I mean, can you imagine? I was like, oh, it's diet. It seems stupid now. But back then, no one really talked about it as much. I mean, it's not like now where we have social media and everything's on it. At the time, there was no social media. I was learning this from books and papers.
But what I find interesting is you are one of many doctors who practice this surgery. So why do you think you specifically made this connection so strongly?
Yeah, that's hard to say. I mean, I think in the field of bariatrics, it's a more dramatic result of what food could do to you. So it was more in my face, and I didn't like, like I would go to these bariatric surgery meetings, and like we would go to a bariatric conference, right? And it'd be a week long, and we're discussing how to treat obesity. And I would sit in that meeting, and like no one talked about food. It's so bizarre now, right? Yeah. I mean, even now when I go to the bariatric surgery meeting, we don't really talk about food. We talk about surgical ways to fix obesity. I mean, we talk about, food gets this kind of, just tell them to eat protein kind of thing afterwards. No one in my bariatric, they all turn to me when it comes to like nutrition science. They don't really study the nutrition science. They do study everything there is to know about, the individual chemicals involved with hunger and how you affect those with surgical procedures. And they could tell you anything you want to know about hormones and cellular reactions to different surgeries, but they miss the forest for the trees, I think is the best way to say it. They're so focused, like scientists are so focused on the minutia, they miss the bigger picture. Like I was in this one scientific meeting I'll never forget. The problems with insulin resistance and how heme iron affects pancreatic beta cells that secrete insulin. And she's going on and on about her work, and excess iron was definitely causing issues with insulin resistance and problems with diabetes. And at the end, everybody's asking her about herb science, very, stuff that would bore you guys. But then someone asked her, what do you eat on a day-to-day basis? And I was kind of like, oh, wow, someone asked her that. And so here's an expert studying heme iron. And she goes, oh, I eat a pretty low-carb, high-protein diet. Okay, so understand the hypocrisy of this, because if she's eating a low-carb, high-protein diet, she is eating a lot of meat. Meat has a lot of heme iron in it. So she's eating the stuff that she's studying and says is bad for your pancreas. And that's when I was like, oh my God, people are totally missing the forest for the trees here.
Yeah, that's amazing. So it must be really challenging being in the medical profession with so many intelligent people who all want to do well, but they just skirt past this problem, partly I think because they are eating the same foods, but it's just not having such a bad effect.
Right. This is very true. Now, I will say I've seen a big evolution. Okay, so doctors are more considering food now, and they are considering what they eat. I've seen a change in the doctor's lounge. I've seen a change in work. But it's still, like, I'll still walk in the doctor's lounge and people see me, they're like covering their food. Like, oh my God, don't look at what I'm eating. Don't look at what I'm eating. That is a part of it. This kind of like, well, I can't tell someone to do something I'm not doing, noticing your own hypocrisy. There's also this kind of like doctor effect of, oh, it's never going to happen to me.
Right.
that probably goes in there a bit. With the surgeons, it's like I think they're just so super focused on the surgical procedure. They do defer to me now a little bit more. I'll tell you, I've had several doctors get cancer and call me up once they've gotten cancer and be like, okay, what do I do now? What do I do? What do I eat? What do I do? And so, there's no atheists in a foxhole. And that's when they really start, hey, well, how do I do a plant-based diet? And so I get more and more. In the beginning, I was like this, what is this guy talking about? And now I get more like a little conversation. Hey, I saw that article you posted. Can you tell me more about it? So there's a little bit more interest. The interest is growing.
So I want to talk a little bit about obesity, obviously, but I want to do it in separate slightly. So I want to first talk about the simple problem of obesity, i.e. the one that people on TikTok and in the world consider obesity to be a problem just related to your own consumption of food, and it assumes you have full control over your diet. So from that perspective, why does a plant-based diet work?
First of all, do we have control? I mean, that's the real focus, is like, do we really have control of our bodies? And I'll tell you that we really have very poor control of our bodies. Some are going to have more control than others, and that's genetic, that's environmental, it could be socioeconomic, it could be so many different things. You look at twin studies. I love looking at the twin studies, because when you look at the twin studies, like the identical twins, separated birth, growing up in different environments, having almost exactly the same weight. They've done feeding trials where they fed people the same amount of calories. But what they did is they took different groups of twins, and you could feed everybody the same amount of calories, and everybody is getting different amounts of weight gain or weight loss based on those calories, because everyone's different, but the twins are the same. So there's something in that genetic code that seems to hold out. There's so many hormones that control hunger. And it really bothers me when people say, oh, this is all willpower. Just, I see like a young 25-year-old athlete on Instagram going, people just need to eat better. They need to take responsibility. And these people, no, they haven't walked a mile in someone else's shoes. And the fact, I think the new meds are pretty interesting because it's such a dramatic example. You got a patient, morbidly obese, sick, right? And this 25-year-old Instagram person is going to blame that person. It's their fault. They have no willpower. Now, that patient takes a shot, and instantly the weight comes off, right? Instantly, the food noise goes away. Instantly, this shot is giving them willpower. That's what it's doing. All of a sudden, they're not eating that much. All of a sudden, the weight's coming down and they're getting healthy. All of a sudden, it's easier to get to the gym, and they're going to the gym. And their whole life is changing from one little shot once a week, and that's doing all that. Now, the other interesting thing is they're taking that shot. All of a sudden, they got willpower by this 25-year-old standard, right? They're going to the gym. They're losing weight. Things are going great. And we trick them. They come to pick up their meds, and we give them a placebo. Now they're doing a placebo shot, and all of a sudden, their weight's starting to go back up. All of a sudden, they're like, oh, my God, I need to eat that candy. I know I shouldn't, but I'm going to eat it. All of a sudden, they've lost their willpower. It's not willpower. It's not the cerebrum, which is the thinking part of the brain that has willpower. It actually is based in the very primitive parts of the brain, the central brain, the neurocortex, the parts of the brain that control breathing and that control heart rate. Those are the parts of the brain that control hunger. I did a little experiment on myself because there's a hormone that comes from the stomach called ghrelin. And ghrelin makes you hungry. And we have different levels of ghrelin, and people have different amounts of ghrelin. Now, I know when a patient gets a gastric bypass surgery for me or a sleeve gastrectomy where I remove part of their stomach, I remove part of the stomach that secretes ghrelin, and they're less hungry. They're just not as interested in food. Ghrelin also is a growth hormone stimulant, and I had an injury, and my friend is kind of an expert in kind of regenerative medicine and stuff like that. I was like, you should take this thing called ibutamoren, which is a ghrelin analog, and it helps with growing back tissue and stuff, but is like ghrelin. So I was like, oh, this will be interesting to see what happens to my body when I take ghrelin. Let me see what my patients experience. Oh my God, I could not satiate myself. I was eating, I couldn't stop eating. It was the most unbelievable feeling. And I am, by anybody's standards, very high in the self-motivated willpower area. And all of a sudden I lost all that willpower. I believe you shouldn't eat late at night. I went down at 2 in the morning and made a bowl of cereal. So what we consider control and when we blame others for saying they lack control is completely erroneous. There are a lot of factors that figure in. And you also, I got patients that work at 2 jobs, have no money, and they could pick up on their way home a big bucket of Kentucky Fried Chicken for $5. It's hard for me to tell them, no, you need to go home and prepare a meal. It's just, we're not in the same boat. We're not in the same situation. And I wish more people understood that. Now, why does a plant-based diet work? Okay, first of all, it doesn't always work. So I get plenty of people coming to my weight loss clinic that are morbidly obese and are vegan. All right, so it doesn't always work, especially nowadays because there's a lot of processed vegan food. And if you've got this, the hormone course of your body make you hungry, you could eat a lot of food that's high calorie dense. Now, if you were a completely whole food plant-based, you're not going to get morbidly obese. And why is that? There's a couple of reasons. Plant food is nutrient dense, water dense, and fiber dense, and therefore calorie poor. And so just from a very simple standard, if you take a stomach and you think like oil, which is very calorie dense, you could take a tablespoon of oil, get a whole bunch of calories, and it ain't going to touch your hunger, right? Your stomach isn't. The stomach actually has stretch sensors in a nerve, the biggest nerve that goes to the brain. And so the more you stretch that stomach, the more you tell your brain you got food in there. If we stretch it with a huge shallot and all kinds of things, you're going to get more stretch than you're going to get with the calorie-dense food. So that's reason number one. Reason number two actually is somewhat tied to the medications, the shots, the Ozempics and Mounjaras and stuff. So those shots are a GLP-1 analog. GLP-1 is a peptide hormone, and it feeds to this primitive part of the brain that tells you you're hungry, and it helps to tell you you're not hungry. It also has effects on the pancreas and insulin resistance. That hormone is actually naturally secreted in the human body at the end of the small intestine. So there's cells at the end of the small intestine, and they secrete GLP-1. What stimulates them to secrete GLP-1? Well, fats will stimulate them to secrete GLP-1. The problem is when we eat fat, we absorb it before it gets to those cells. But if you eat very green vegetables, I'm getting very technical here.
Please do.
Yeah, but these very green, that green color, all right, that chlorophyll that makes it green, have these chemicals in it called thylakoids. Thylakoids block our enzyme that breaks down fat. So the enzyme that breaks down fat gets secreted by let's say you have a salad with some olive oil on it. And the enzymes that break down fat, lipase, will come over there and they'll break down the olive oil. You'll absorb it before it gets to those cells that secrete GLP-1. But if you've got the spinach there, the spinach will actually block the lipase. Now the olive oil can get all the way down to the small intestine, and the small intestine says, oh, here's fat. We need to put on the brakes with the food eating, and it will secrete GLP-1. Green foods help secrete GLP-1, as do other foods, but specifically green foods will help decrease GLP-1. And I think that's part of the issue. So if you're eating a lot of greens, you're getting more GLP-1, you're getting full faster. The other thing is that plant-based eaters are eating a lot of fiber. Fiber feeds the microbiome. The microbiome, if you have the right microbiome, secrete these short-chain fatty acids that stimulate these cells to secrete GLP-1. So over an extended period of eating a plant-based diet, you're fostering the kind of bacteria that promote more GLP-1 in the system, so you're less hungry in general.
So are these all the same reasons why you wouldn't recommend a keto diet?
Oh, yeah. I mean, well, there's many reasons I wouldn't recommend a keto diet. First of all, I've been doing weight loss for 23 years now. I've never seen a long-term keto diet success. I've only seen people coming to me with keto failures. Granted, if they were a success, maybe I wouldn't see them, but I just haven't seen that. But yeah, they lack fiber in their diet. They certainly are getting calorie dense foods. They're attacking the keto diet. People are trying to attack hunger through a different mechanism, and that mechanism is through keto acids that could also create satiety and nausea. And so they're trying to attack that hunger through a different method.
I've heard you define obesity as a disease. Can you say a little bit about that?
Well, it goes back to what we were just talking about. I mean, it's a disease in that there's a genetic component to it. It's a disease in that it has a definite and real effect on your health and your health outcomes. It's a disease in that we do have treatments for that. And so for all of those reasons, I do consider it a disease. I don't consider it something that it's same thing like if you're born with asthma, I consider, that a disease, and I'm going to treat that. So in that regard.
Yeah. I mean, I agree. I kind of defined it in my own life as a biological, social, and psychological affliction.
It is. That's a perfect description. Yeah.
Yeah. It covers.
And part of it is also, you got to understand that if you go back to our origins and how we evolved in times of feast or famine.
Yeah.
So we evolved a really big stomach. When I take out people's stomachs, it's huge. I mean, I could stretch them and blow them up. And that's why you could go and get your dollar's worth at a buffet. But that stomach was made because when there was food available, you better eat a lot of it because there may not be food available again in the future. And we've got this very complicated system, which isn't a bad system if you live in ancient times, there isn't food around. And it's based on something called leptin. So our fat cells secrete a hormone called leptin that feeds back to the central part of the brain and gives the brain an idea of what our energy stores are like. And so this worked back then, because if you were going through a famine and your fat stores were down and your leptin was down, your brain was telling you, don't sleep, don't rest, go and find food. And so now that works against us because we go on a diet and we drop fat, we drop leptin, and our brain's like, you better, you go on a diet, at the beginning of the diet, you're like, no, someone offers you cake. You're like, I don't want cake. But then, 3 weeks into the diet, someone offers you cake. You're like, oh my God, is that Betty Crocker? I want that cake. And you think it's a willpower issue, but really it's the ghrelin hormone, it's the leptin hormone. And these hormones were designed to help you survive famine. They weren't designed for a situation where there's food on every corner and everywhere you turn.
So when I was looking at this problem of obesity, what tends to be out there is like 3 ways to deal with it. One, people talk about changing what you eat. The second way, they talk about changing how much you move. And then there's the approach that you do, specialize in, which is changing the body, right, with drugs or surgery. So I want to start.
I do all of those things.
Right. Yes, excuse me. But that your how I got to speak to you is through the third one, but yeah, you do all of them. So I want to ask you about all of them in turn, just to see how we get with this. So modifying what you eat, you've already spoken about that. But what I really like about what you bring to the plant-based movement is you talk about how difficult it is for people to make this change. And I think that's such a hardship for people who don't get the results right away. I stayed really obese as I went plant-based for many years, and I was ridiculed. People would say, you can't be vegan if you're fat, and you must be eating KFC on the side. Like, they would accuse me of cheating. And can you talk a little bit about the misunderstanding of just how hard it is for people who have those hormones and those genes moving, how difficult it is for them to make the lifestyle change?
Yeah. So imagine we've evolved and we've got these chemicals in our body that are supposed to protect us against starvation. And imagine in ancient time, what we were evolved to do is eat the highest calorie density food possible in order to survive. And we have certain tastes because those tastes drive us to eat foods that are going to give us calories. And then imagine a taste scientist comes along, and that taste scientist says, what is the human body designed to be attracted to? And how can I manipulate that so I can get people hooked on it so that they're paying me money? And that's what we got now, right? We've got this hyperpalatable, high-fat, high-calorie foods that we are naturally attracted to, that are being packaged and sent to us at very cheap rates, that are extremely hard to resist. It's extremely hard to resist the Pringles potato chip. The crunch, the taste, the way it dissolves, this has all been designed by testing it on humans and seeing what we are most attracted to. And so these taste scientists are taking advantage of that. And so you want to go vegan and you're going to eat fruit for your sweet taste buds, but meanwhile, someone's got, a fruit candy that will give you 10 times the sweetness, and it's easier to get to it. It's easier to eat. You can eat more of it, and you're going to be naturally drawn towards doing that. Diet changes don't result in these massive weight losses in the speed of time you see with some of the other interventions. And so you change your diet, and in the beginning, you lose a pound. You can barely see it because you've got to lose 100 pounds, and you don't notice it. And you're like, I'm working so hard. I've got all these like attractions to these other foods. I'm fighting it on a day-to-day basis, and I'm not seeing anything. Not so I quit. Right. And so it becomes a very, very difficult situation, and a lot of people quit because of it.
And also with other types of, let's say, compulsive behaviors, your social group will help you stop. Like if you've got an addiction to a hard drug, people aren't just going to give it to you. With food, you can tell people, I have an issue with food. They're like, that's really difficult. Would you like a cake?
Right. No, it's true. Right. It's absolutely true. Like, so like an alcoholic, if they want to go cold turkey, they could go cold turkey. They don't need to drink alcohol. It's not, but we still need to eat. So we still need to make that decision. And the other thing is, and people forget this, like they've done these really interesting, just really elegant studies where they took people and put them in what's called a functional MRI. And a functional MRI, it'll measure your brain activity. And we could look at certain parts of the brain that represent desire. And we could show, for instance, a cheeseburger. And you could show it to one person and their brain is just like, yeah, it's interesting, but not that big. You could show it to an obese patient and their brain is like, oh my God, I need to have that right now. And in fact, if you look at the arcuate nucleus, which is a part of the brain where dopamine receptors exist, and they found that people that are overweight tend to have a lack of dopamine receptor in the arcuate nucleus of the brain. And that basically means it's very hard for them to get satisfaction. And their brain looks very similar from a dopamine receptor standpoint to an addict's brain. So again, this goes back to the 25-year-old Instagram person yelling on his feed that, oh my God, you should just do what I do and you lack willpower and you lack this and that. Meanwhile, he's got a bunch of dopamine receptors. He eats his, whatever he eats and he feels satisfied, whereas the people he's yelling at can eat the same thing and not feel satisfied.
When I looked into the work that you do, it just brought back so much of my own journey with this, and it's very confirming to hear it from a specialist about this subject. Like I'd spent time standing on a corner with the junk food shop this way and the health food shop that way, and I could be there 45 minutes, like working with this yes, no vibe. And what just came to as you were speaking is I thought weight loss was something that happened to my body. But I've lost 70 pounds over the course of about 10 years. But what I'm thinking now is maybe the dedication that I did was just rewiring the brain to like be more able to deal with these ups. I still have them. I haven't gone away, but I feel like I'm a little bit more able to manage these urges and surges that appear from time to time. What do you know about that?
Yeah, so there's a technique that we use, a psychological technique we use with our patients as they're making changes called cognitive behavioral therapy. And cognitive behavioral therapy, I mean, there's many reasons, as we talked about with obesity. We've talked mainly about physiologic, but there's certainly psychological issues. There's habit, there's how you grew up. There's, like you said, your friends. We know that zip codes can have the same obesity rates, etc. So how do you change from those habits and those psychological issues? And we found that people get really bad psychological issues. I mean, we're talking like childhood abuse that drives them to eat. And we could talk about that childhood abuse and they can go through psychoanalysis and they could come to terms with it, but they're still going to have this bad eating pattern. And one of the ways to really counter these bad eating patterns is through cognitive behavioral therapy, which is really kind of setting up habits and rituals. And the more you do these habits and rituals, it's just like working out. The more you flex the muscle, the more you make that neural connection, the stronger that neural connection becomes. And then it becomes more of a habit.
Like, it's really fascinating because you describe what I describe, but you use a more sophisticated language. I said to my friends, I feel like I've been in this emotional trauma, cravings situation where I built all these habits around food. And when I went for this process of like repairing myself, the habit's still there. It felt like I'd created a plaster of Paris. I'd taken my hand out, but the shape, the behavior was there. It became a habit. rather than like it was caused by the food, the biology, the cravings, etc. But then it became a really ingrained habit that then had to be worked on as well. Is that what you're saying?
Yeah, exactly. I mean, pretty soon that plaster you talk about is, so I don't know, you know the concept of neuroplasticity, but we can make these neural connections in our brain, and the more you use them, the stronger they become. And you can change pathways in your brain. You can teach an old dog new tricks. But it just takes a pattern eating behavior to do that. And by the way, if anybody's interested in cognitive behavioral therapy and how to change habits, 2 good books. One excellent book is Beck's Diet Solution. This is written by Judith Beck. She's really one of the forefathers of cognitive behavioral therapy. Her dad actually invented it. And she's got a great book for people trying to lose weight called Beck's Diet Solution. It doesn't talk about diet at all. It talks about how to create these habits. And Atomic Habits is another really good book about how to create these new habits and create these new neural connections.
So basically, when I looked at this problem for myself, I saw that there was genetic component, there was a cravings component, there was a cultural component, there was a biology component. Everything felt like it was against me to stop me changing. Then I realized one day that the one thing that wasn't against me were plants. I realized that even if I couldn't stop the binge eating, I couldn't stop the out of control eating, if I could just get onto a plant-based diet, the harm would be less, and that would buy me more time to solve this. Do you
exactly
agree with? Okay, you do agree with that. Because
yeah, because if you're a binge eater and you switch from binging potato chips to binging pickles, or binging watermelon, or binging blueberries, yeah, you're gonna have a totally different result.
Yeah.
Look, you could binge and eat, quite a few blueberries, but it's going to be hard to get up to those, calorie counts that some of these other foods get to. And so if you could make that change, which is still hard to make, you're going to have a definite change and a definite improvement. I mean, I always tell people, technically there is an amount of apples you could binge on where you would gain weight, right? I mean, there's a calorie count, like in the very end, when you go through everything, in the end, it is calories in, calories out. So if you are eating more calories than you burn, and there's many complexities, so it's not that simple, but if you're eating more calories than you burn, yeah, you're going to gain weight. But how many apples could you possibly eat?
Exactly.
You just can't eat 10 apples. You can't eat 2 apples. Who eats 1 apple and then has another apple? In the pectin, the fiber, the water, this kind of stuff is going to satiate you eventually. The hard part is making that first choice that I am going to reach for the app. So part of cognitive behavioral therapy is this thing called implementation intention, where for instance, that at midnight, you're going for ice cream. You want something sweet. So instead, say, I know that at night, my habit is to go for ice cream. And if I'm going to go for ice cream, instead, I'm going to have an apple. If after that apple, I still want ice cream, I'll have it. And I'm first going to eat an apple. And what you'll find is if you start doing that over and over again, the apple will satiate you and you will not need the ice cream.
Yeah, it's very, and also, do you have, I think you mentioned this earlier, but I found that when I switched from binging on animal-based foods to binging on plant-based foods, what I noticed is that the animal-based foods, I never felt satisfied. It wouldn't matter how much McDonald's or pizzas I had. I felt bloated and full, but the hunger never went away. When I started, let's call it binging for now, on plant-based food, there was a genuine satiation point. It was still quite far down the road because I was eating a lot, but there was one.
Fiber. There's fiber in it. Right. And there's no fiber and there's no water in those other foods.
Great. So the other point I wanted to pick up on was that you mentioned that exercise decreases metabolism based on that Biggest Loser study, or it can reduce metabolism. What about muscle gain, strength training versus, say, cardio as a way to repair metabolism?
So there's basal metabolic rate. That's how much you burn if you just sit there standing still. If you are in calorie deficit, I mean, they've gone and studied, what's the tribe called? Anyway, a tribe that is still eating their kind of more ancient ways. They walk all the time, they're running all the time, and they're really thin. And so the thought from the scientists would be that they had a pretty high metabolism, and no, they had a very slow metabolism. And the reason is the body's really good at trying to, back to what I told you about. Natural selection and evolution was to get us to survive famine. And if we're moving a lot and we're losing calories, the body will save it elsewhere. It'll save it in ways you wouldn't even think about. Nothing to do with muscle. It'll save it in cellular processes, cellular turnover, kind of things that you just wouldn't even think about. You know, if you tell me that somebody has 80 pounds of muscle on their body and someone else has 70 pounds of muscle, I know the person with 80 pounds of muscle is burning more calories with their basal metabolic rate. I know that. It is essential when you're actively losing weight to try to maintain muscle mass as best possible. And how do you do that? You don't lose weight super fast. You try to do it slowly. So even when I can't do that with surgery. When I do surgery, they're going to lose weight pretty quickly. But with these medications, I see a lot of people taking the medications, and they go straight to the highest dose possible as fast as they can so they could lose as fast as they can, because that's let me get there as fast as I can possibly get. I see with those people a very big drop in their metabolism. And that will be a real problem because they are really shocking the system, and the metabolism drops really quickly. And that's partly, it's not all muscle mass loss. The metabolism will slow regardless of muscle mass loss just because of what we talked about, cellular processes and things like that. But they do lose muscle very quickly. If you are in a calorie deficit and you are not exercising, you will lose muscle. You can counter that with resistance training. And that's why I'm so big on resistance training. It will counter some of that muscle mass loss. And if you're able to build muscle, it will increase metabolism, not huge amounts, but it will increase metabolism. Plus, it increases your daily burn. I mean, going to the gym, working out, you're burning calories. Maybe it's only 400 or 500 calories. It's still 500 calories. And if we're trying to get any, net calorie negative, movement is important. So I'm not asking, I don't want you losing muscle. I'm not as concerned as what your basal metabolic rate is as I am how much you move during the course of a day.
Right. So I did 2 rapid weight loss periods about 10 years ago. I lost about 80 pounds each time doing like fasting or juicing. My metabolism ended up at about 1400 after that.
Yeah, that's really low.
I didn't know that was the case. I did a juice fast, then it didn't work. I put all the weight back on, and I did it again, and it went back. And I thought, okay, that's not going to work. 1400. Yeah. I've now built it back up to 1900, but I'm still 240 pounds, and 1900 feels a bit on the low side. Is there any other way that you can like what I want to ask you? The point of this point here is that is obesity, once you've had obesity, is part of it irreversible? Like you're always going to have the fat cells, you're always going to have the imbalances, you're just going to work with it. I will get onto the surgery in a minute. I mean, is it reversible without surgery or medication or?
Yeah, that's a good question. So fat cells are pretty much irreversible, the number of fat cells. But when you get fat, it's not increasing fat cells, it's increasing the amount of fat in the cell. So you could change that pretty easily. Metabolism is harder. Yes, as you build muscle, as you probably have, you will bring your metabolism back up a bit. The Biggest Loser study was pretty impressive as to how badly, so they took these Biggest Loser people and they put them on this like very low calorie diet while working them out to almost death, and their metabolism just gutted. And then 6 years later, it hadn't returned. And there's many theories and arguments as to why, because when they still exercised afterwards, interestingly enough. It's not like they did the exercise during the program and didn't exercise afterwards. They interestingly were able to keep exercising, but they could never get their metabolism back to where it was before. And that may have just been the extreme nature of that individual study. But I don't think you have to worry that much. I wouldn't concern yourself with that number in the metabolic scale, because you're going to do a better job worrying about how many calories you expend in the day moving than you are about what your basal metabolism is. So maybe you could take your basal metabolism from 1500 to 1600. That's an extra 100 calories you're burning. Big deal. But you could go and do 10,000 steps and go to the gym and, walk on the treadmill at a higher rate. And you could end up, burning 1,000 calories in a day. And so that's going to be a much bigger and more important aspect of your weight loss than will be your basal metabolism.
It almost seems like the way that the body kind of cleverly works, that if you do start exercising a lot, it might even reduce your basal metabolic.
It will. It will do that.
Need it anymore if you're already
right. I wouldn't worry so much about basal metabolism. I would worry more about And when it comes to strength training versus cardio, both. I do both. I try very hard to maintain my muscle mass. I'm not a bodybuilder. I want to be a bodybuilder.
Right.
It's not my aesthetic. But I lift weights to be healthy, to live longer, to be stronger. When I lift weights, I don't do it. It should be enjoyable. I tell my patients, there's been all these studies. They did an interesting study recently where they had people do leg extension exercises. And on one leg, they went to failure, meaning if they were prescribed 10 reps, the 10th rep was almost impossible. They could barely get it up, and they couldn't do an 11th rep. On the other leg, they did 10 reps, but they could do 12 reps. So the weight was such, it was a lighter weight on that side. So not that they could do 15 or 20 reps, but they could do 12 reps, but they quit at 10. There was no difference in muscle gain in both legs. So the other thing is we overdo this. Like, you tell someone weight training and they picture someone screaming at them, do one more rep, all that stuff. Doesn't need to be that. You just need to move the muscle with a little bit of resistance, and you will have a world of benefits. I mean, you will have changes in your metabolism. You'll have changes in your strength. You'll have changes in the tone and the way you look. You'll be more insulin sensitive. You'll live longer. You're less likely to fall. Your bones will be stronger. All to do like 30 minutes. Challenging, but not like I'm going to die and hurt type challenge. It doesn't need to be like that. Meanwhile, cardio is really important. You're going to burn more calories in a cardio exercise. So there's a lot of, the debates online are so just moronic. People are like, oh, weightlifting is better for weight loss because of this. And then cardio, people know it's better because of this. You do both. Now, cardio is going to burn more calories. Now, if you're doing a lot of cardio and you're not eating a lot of calories, and you're in a calorie deficit that you're pushing and you're really stressing the body, you're going to lose muscle. So you don't want to do really hard cardio when you're at a really low calorie deficit. But again, the cardio should be light. I love this concept of zone 2 cardio. They call it the fat burning zone because your body uses mainly fat. Does use some carbs, but mainly fat during a lower intensity cardio. Not that makes you burn more fat necessarily, but it is this zone that is really that you can maintain for 30 to 45 minutes pretty easily. That is really good for your heart in aerobic capacity. And so like this afternoon, I'm going to go for a run. Today's my zone 2 day. I'm going to go for a run with the dog, heart rate on it, and I'm not going to go over 180 minus my age for heart rate. I keep it below that. That's my zone 2 cardio. And so it's not hard. These don't need to be challenging. You don't need to kill yourself. And they are very, very helpful.
It's so helpful to hear you say that because when I found my introduction into this sort of world like 20 years ago, it was so radical. Everything was hardcore, 100% raw, fruitarian, or work out to the max. And what I actually found out was a plant-based diet and cycling just to do errands was enough to repair my HbA1c to non-diabetic. Now it's like 5.6 most of the time. And I lost about 70 pounds. The bit I'm struggling with now, and this is why this is so fascinating to me, is the next part of the weight loss. And I now realize that's going to require strength training, which I've never done. So
strength training is crucial, especially for that last part.
Yeah, this is what I kind of realized. So it's really fascinating, like talking to someone that has been studying this like professionally, and I'm just a lay person, and I've arrived at these conclusions, but I didn't really quite understand the science behind them. So the next thing I wanted to get into now, which is so you've had this really strong confirmation for me, but the next bit is what blew my mind was when you said that it was really quite shocking. It's like nothing is as effective. Like lifestyle medicine, i.e. food, isn't as effective as surgery. Like, I've never heard anyone say that. Like,
oh, it's not even close. It's not even in the same realm because the surgery is totally defeating this central evolved. I mean, I'm taking out the part of the stomach that stretches, that makes you. So now you eat smaller and you get a stretch that you wouldn't have gotten before. I'm getting rid of these hormones that control hunger. I mean, you lost 70 pounds and you've been struggling like you talked about over what period of time?
Years. It took me, the 70 pounds took 10 years, but before that, it was 10 years of no progress.
Right. So if I'd done the surgery on you, your A1C and that 70 pounds would have been down in 3 months.
This is why I find this part of your work, I agree, but I'm like, ouch, but yes, like it's a lot
I mean,
of
it's tough medicine. People people hate to think that these things work, but they do. I mean, we've got 30-year data. We show it extends lifespan. I mean, it makes people like, I'm scared of dying from the surgery. You are way more likely to live longer after the surgery.
Right.
The surgical benefits are, we have done so much research on the surgery at this point that it's irrefutable. Like, I hear people like Joe Rogan and stuff saying stuff about surgery. I'm like, oh my God, you are a moron. We have science. This is a fact. This isn't an opinion. There's no opinion. The surgery works, and it works extremely well. Now, are there people it doesn't work on? Yes. Are there people that regain weight? Yes. But the vast majority lose weight, keep it off, live longer. 85% of people have their diabetes completely cured, where they go off their medication, their A1C goes to normal, and the surgeries work. I wouldn't do the surgeries if they didn't work.
How I kind of saw this and how your surgery fits into my mind is that I was thinking, I'm the characteristics that I have that made me overweight were all survival traits when there wasn't a lot of food. I will get food if it's around. If I can see something over the horizon, I will get there. I don't lose fat fast, so any food I get is going to keep on my body. I'm low dopamine, so I'm very I have to get it. Like, I have to work hard to get it.
Exactly.
All these things were keeping me alive when there was a period of not abundance. Now I found myself in this abundant world. I started to feel like I'm being evolved out. Like, big stomach people like that, who my kind of constitution, we are being evolved out of existence because of the ill health we are facing. So my question is this: it's a bit of a weird one, but is bariatric surgery sort of like forced evolution? You're just like, it
is. If obesity killed you before you could procreate, then natural selection would favor a bariatric type anatomy, a smaller stomach. We don't need, so we have a really long small intestine that absorbs calories all the way along it, all the way down. If I could bypass some of that intestine, you will have less diabetes, less hypertension, less cholesterol, better joints, live longer, all that stuff. So the only reason we don't evolve to a bariatric type anatomy is that we can procreate prior to
that's a good point.
Get into that level. If obesity, instead of being a chronic disease, killed you at an earlier age before procreation, we would evolve to a smaller stomach and smaller intestinal tract.
Okay,
because it would be preferable to make you live. It's just that it's a chronic disease. We die older. Right. We've already procreated and passed on the genes.
Like coming across your work, I do feel a bit conflicted. I will say that, because I work so hard to do this.
Yeah, so people talk about, is it cheating to do these things? And, I definitely don't think it's cheating. I think if there's a tool that helps, I'll take any tool there is to help me if I have an affliction or a need. Not everybody is going to have your ability to, first of all, afford the foods that you eat. Second of all, have availability. I mean, we live in food deserts here in America where people can't, there's no grocery store with, natural organic fruits and vegetables. There's an education problem. So for some patients, it is the way that will help them make the change, and they just simply can't make it the way you did.
I think this is where I ended up with this, was that I happened to be in a position whereby I quit my job to do this. This became a full-time thing for me, and it's the hardest thing I've ever done, and it took 2 decades, and I'm not done yet. So I think that, what did I get out of that? I did get a lot out of it. It changed my view on the world. It changed my view on life. It gave me a lot of life enriching processes. But does everybody want to go through that? I don't think they do.
Not only do, and I don't even know if it's do they want to go through that? It's can they really go through that? Can they quit a job when they've got single mother with kids and working too? It's just one of those things where we're all in different situations. But the vast majority of people can't do it. There are people that do it. There's people like you out there. I see them. But the vast majority have a really hard time with that. And if there is a treatment that can make this happen for them and make them live longer and make their quality of life improve dramatically, why wouldn't they do that in that situation? And things are changing now. I mean, it used to be surgery. Now we got medications that are doing that. And that's the way we're going.
No, it's a really good point, because for me, it's like, I think I wanted that path of self-improvement. I was already aligned with that, and this just became the focal point. But it took a lot, right? And I think someone else, there's other ways in which you can find what's needed to improve your life. You don't necessarily have to center it around something that is high stakes. Like messing around with binge eating and diabetes for 20 years is a high stakes game. And luckily, I feel like there are scars, like my body isn't completely repaired, but I've got through it. But some people, it's a game ender. So you've changed it's a bit mind blowing, but you've changed my view on surgery as a tool, as a compassionate tool for those people who don't have the time, don't have the ability, don't want to, or just not in a fortunate enough position to be able to dedicate themselves to something which is difficult.
Right. And also keep in mind, it's not like they don't have difficulties. They still struggle afterwards. They still have to make these changes. And there's going to be some, I mean, I've got patients that become marathon runners and Ironman and all that kind of stuff. There's some that still go through the same thing you're going through. They're just they're just compounding their winnings. They're having just like huge benefits from their exercise, but they're still exercising. They're making real life changes. They're using the surgery as a tool to help them make those life changes, but they are making life changes. They are making tough choices. The surgery changes your hunger and all that kind of stuff, but you still have to make a choice every time you sit down to eat.
How do you decide, or who decides whether or not to incorporate the surgery or the drugs?
Well, I mean, the decision is basically a medical decision. We know there's a certain, and we use body mass index a lot, though, and it's not the most accurate thing, but we use this body mass index concept because it's a fairly standard concept. And for most people, they could tell me whether or not they're carrying excess body fat. To qualify for surgery, you have to have a body mass index above 40. And again, this is your weight divided by your height in meters squared. So weight in kilograms, height meters squared. Really, you have to calculate it on the computer, look up your body mass index. Above 40, we know that the surgery is definitely beneficial. There's no question. There's no debate. Like people try to debate this. It's just dumb. I've got like a library of articles that would show that this is beneficial on just about every different disease process, on longevity, on quality of life. So above BMI of 40, there's no question. Between 35 and 40, it used to be debated, and we came to the agreement that if it's between 35 and 40 and you have a comorbid illness like hypertension or diabetes or sleep apnea, then the surgery could be done. Recently, that's been dropped even lower because newer research says that even with the BMI between 30 and 35, you benefit dramatically from the surgery, especially if you have diabetes. Like diabetes is huge. So like if you're diabetic and your BMI is 33, you would benefit from the surgery. The caveat with that is the meds have come along. And a BMI, of 33 can do the meds and have a great result without needing surgery. So it looked like there was going to be a move to actually increase the number of surgeries until the meds came along. And now the number of surgeries is about almost half. And so, but I mean, we consider treatment for obesity above a BMI of 30 now. Or a BMI between 27 and 30 qualifies for drugs if you have comorbid illness.
Right. Well, I'm in your qualifying camp because my BMI is still 32. It's come down from 38. But I'm getting really good. My HbA1c is like 5.6. It's been like that for about 6 months now. So the other question I had...
Now, but like if you came to me, you're like, I've lost all this weight. My BMI is 32. I would look at your percent body fat. I would look at your skeletal muscle mass. And more than likely, I would not recommend any therapy to you. So if you came to the clinic with me, we would be talking about how can we get that last bit off without doing any therapy. I certainly would not recommend surgery on you. No way. I don't ever recommend surgery under a BMI of 35 ever. But with you, I would likely not recommend any of those things, and we would work on it in a different way.
Yeah, I do feel like I've got this now, but we'll see. My brother's on Ozempic. He's on that, and he has a psychiatric illness, so he doesn't really have and he has diabetes. He doesn't really have the capacity to really confront these cravings. So they put them on that, and that's working quite well. And that's another area that's like with all these people who say calories in, calories out, just go and do it. There's so many people that have so much difficulty just getting up in the morning. And it's like, and now you want them to battle this evolutionary tide, that telling them to eat donuts. I mean, the compassion is sometimes missing, and that's what I like with it's refreshing to come across a doctor that's like, actually, this is really hard, guys. So we do need help. How do you see the future of obesity? Like, we're in trouble, right? 60% of people are obese, and you're doing your best, and I'm trying to be a role model for that, and it's really hard. How do you see this panning out from your perspective as a professional?
In the next 10 years, there'll be very few obese people. But it'll be a real small amount of people.
Wow.
There will be a pill. You will take the pill daily, like we take statins for cholesterol, and like we take other medications, and that pill will control hunger cravings, and it will definitely reduce the amount of obesity. I think the medications are getting better and better, and the future of obesity is going to be a disease that we really are successful with.
This might be not your area of expertise, but don't you think the food industry is going to have something to say about the availability?
They hate it. Oh, they're already. Everyone fears this drug. You don't understand what this drug has done to my business. Like, absolutely. Like when I used to do weight loss surgery, I thought, I'm never going to run out of patients. It just seemed like there was just like I never thought, oh my God, I won't have patients. And now I do medical and surgical. So, I'm both a bariatrician and a bariatric surgeon. So my business used to be 90% bariatric surgery, 10% bariatric medicine. And now it's like 90% bariatric medicine and 10% bariatric surgery. There's been these just dramatic shifts in medicine. We are finding that these drugs do an amazing job for heart disease. They do an amazing job for arthritis. We're finding that they may do an amazing job for addiction. These drugs are game-changing, and they are the tip of the iceberg of drugs that are in the process right now being tested for in phase 2 or phase 3 trials. We are starting to crack the chemical code that controls a lot of our thought processes, and there's going to be some dramatic differences in addiction. There's going to be dramatic differences in anxiety and all kinds of stuff. So I think the future is pretty bright for medicines. A lot of people in the plant-based world hate pharma, and they're always like, "Oh, you're getting paid by pharma." Man, I wish I was getting paid by pharma. That'd be nice. It would be really great when my surgical volume just got slashed in half. But no one's getting. The only people getting paid by pharma are their specific consultants. You can look them up and see if they get paid by pharma. I don't get a penny from them. This is just the facts. This is what the science is showing.
Yeah, regarding, and that's a really bright future, and I really like your answer regarding the plant-based world's view on pharma. What I say about that is, because I used to think that way a bit as well, but what I say about that is that when the dream of a plant-based diet works, there's nothing better. When you just find someone, right, but you don't. The problem is nobody sees the ones who can't do it struggle, or they're ridiculed out, or denied, or shamed, or kind of put aside, and that's the bit where I feel the support is most needed.
And I'll tell you where pharma fails. And pharma fails in this regard. Pharma is very valuable. They could help. The problem is when we use pharma instead of, rather than with lifestyle change. And I see this a lot. And I don't blame my colleagues in medicine. It is hard, as you have illustrated for us, it's hard to change. And I've got my colleagues have 15 minutes with a patient, and they're supposed to change their lifestyle. And so you got a guy, LDL cholesterol is 180. You know from the data that at 180, he's at risk of early cardiac mortality. You could tell him to eat less saturated fat and follow the portfolio diet and eat more soy and eat more fiber, but come on. How much are you really going to be affect this guy with a 15-minute visit once a year or twice a year? But you can significantly decrease his LDL cholesterol and his cardiac mortality by giving him a little pill he takes every day, which he'll take. And so in the end, we chase our tail. We're eating saturated fats that are increasing our LDL, and the only way we're treating it is by addressing the LDL rather than the saturated fat. And that will continue to be a problem. The better the drugs get, I think the less we look at the lifestyle changes, which is a little bit sad.
Right.
In my practice, I like them to be co-evolved. We're using the meds to help you make the lifestyle changes so that you could be the best self you could possibly be.
Right. That makes a lot of sense, and that's a good point to end this conversation. So thank you so much. It's been really fascinating, and I'm really grateful for the work that you do, especially with the people that really struggle with this and they need that support.
Yeah, thank you. Thanks.